Our first panel this morning is going to speak to efforts that are ongoing in 3 states across this country, West Virginia, Michigan, and Iowa, to address opioids, opioid abuse, opioid misuse, opioid addiction, and opioid overdose. So this is a problem that we've seen really explode in our communities over the past decade, and we're going to start off this symposium with a careful look at what's going on in 3 states around this initiative. So I'd like to invite our 4 panelists to come up to the front of the room, and we'll get started with that panel right away. I'll also say that while our panel is coming up and getting ready, we will have a Q&A session that follows the panel. The panel is going to speak for about an hour, and then we'll have about a half hour of Q&A. And if you could be sure to use the microphones on either side of the room whenever you speak. We want to make sure that we are including our online audience, and they won't be able to hear us if you speak from your seats, no matter how well you project or how big your voices are. So we'll be roaming the room with the microphones when we get to that Q&A session. But please be mindful that we want to make sure that we are including our online audience in the Q&A section. All right, so we're going to start off with some opening comments. The opioid panel that is presenting today is the result of a collaboration that was sparked by support from the National Center for Injury Prevention and Control. So the National Center for Injury Prevention and Control is very interested in translation activities. And toward that end, the 4 centers represented here were successful in competing for a grant that looked at strategies for translating the available evidence on opioid overdose into state-level policies. So we're coming toward the end of that project. I wanted to start off by giving you sort of an overview of how this project sort of came to be, and then we'll turn it over to the panelists to talk about the status of where things are in each of their states. So with regard to what this project is about, the key goal here is to get information to state policymakers regarding what we know about opioid use, misuse, abuse, and addiction. We don't have all the answers by any means from a research perspective, but we do know something about what works. There's an evidence base out there. It's ongoing and is continuing to be developed. But there is, I think few would argue, sort of a disconnect that exists right now between the people at the federal level, at the state level, at the local level, and what they're doing with regard to policy decisions and the evidence base that exists. And those challenges with regard to translating the evidence base, maybe are rooted in a couple of things. So one, when we talk to policymakers, one, of course, is the timing, the difference in sort of the work pace of researchers versus policymakers. As a researcher, I think I can safely say this, we tend to be on sort of a long schedule. We like complete answers. We like to be able to collect all the data. We like to be very certain that our analyses are accurate, and we're oftentimes quite reluctant to come forward with definitive solutions until we're quite certain about what the evidence has to say. In contrast, policymakers are on a tight schedule. They work in response to emerging events, and oftentimes when we talk about state policy, policymakers are working on a very truncated schedule. So here in Maryland, our legislative session is 90 days. So the idea of pondering a problem and considering all of the evidence during that 90 days just isn't possible. So the timing is quite critical with regard to addressing this challenge of translating the evidence to policymakers. But so is the question of the type of information and evidence that's valued by policymakers compared to researchers. So again, policymakers want answers. They want to know what they can do to address a problem. In contrast, researchers are oftentimes quite interested in the methods that we use in order to study a problem. We want to know sort of precise statistics about things. And oftentimes, the sort of methodology and data around a particular topic are of great interest, sometimes even more interest than the solutions to those problems. So getting those two types of informations to come together and come together in a way that the dialogue between researchers and policymakers can happen in a satisfying way is critical, and it's one of the challenges that we faced with this initiative. But I think what binds us together is that what we're all interested in the field of injury prevention and control, regardless of where you sit, is this common value, the commitment to reducing the burden of injuries on the population. But this project that we're talking about is really at its core about how to overcome these challenges with regard to translation. And where we started with this opioid issue was a few years back, I guess it's about 5 years now, and it involved a collaboration with the Clinton Foundation and specifically the Clinton Health Matters Initiative, who were just a fantastic partner that is doing a lot with regard to addressing the opioid issue around the country on a number of fronts. And the Clinton Health Matters Initiative was quite instrumental in terms of helping us how to think about the different stakeholders and networks and messages that we needed to frame our evidence, presentation of evidence around this issue in order to be effective for policymakers. So, and is sort of a start in how to get the evidence into the hands of policymakers. Our overall goal when we sat down with the Clinton Health Matters representatives was to make sure that we could get a sort of a straightforward, clear message from a diverse community of people who were stakeholders in the opioid issue. So we went through this process that's listed here on the slide. We looked nationally for experts who were writing about this issue, who were engaged on the front lines of work on the opioid epidemic. We then invited those people to attend a 2-day meeting here in East Baltimore, actually in this room. At that meeting, we reviewed the available evidence and identified places in the evidence that we could all agree was solid, was grounds for moving forward with regard to policy. And then based on that agreement with regard to the state of the evidence, we developed a series of consensus recommendations. We then went into the process of disseminating that summary of the evidence and the recommendations to stakeholders, policymakers around the country who could use that evidence. What we're here today to talk about is sort of phase 2 of that process. That report was released about 2.5 years ago. A lot has happened in between then and now. As part of this project, we've updated the report. It will be released soon. And we're working with our colleagues in 3 states to figure out how to adapt these recommendations to meet the needs of the opioid crisis in each of their states. So this working with stakeholders is part of the process of disseminating the recommendations to those policymakers who can use the evidence. And then the last point that I have here in this process of responding to the challenges with regard to translating the evidence on opioids into policy is making sure that we respond to stakeholder interest. So once the report is out there, it's in the hands of people who can use it, make sure that we're responding to questions that come up as people want to move forward with different policy ideas. And I just briefly want to share with you some of the documents that came out of that first meeting. We followed up that first meeting with a brief sort of 2-page consensus statement summarizing what we had agreed to in the meeting. And then we went to work developing the report, which again we're updating now. But that report put forward a summary of the available evidence at the time. It focused on sort of the evidence base behind the recommendations for policymakers that we were offering. It was heavily cited, and it included lots of contact information. And ultimately, the report that was put forward, this is the cover of it 2 years ago, included 7 content areas in which there were associated recommendations. So we had evidence and recommendations around engineering strategies that could address the opioid issue, prescribing guidelines, pharmacy benefit managers and pharmacies, prescription drug monitoring programs, naloxone distribution, community-based initiatives, and addiction treatment. So those were the 7 areas that rose to the top with regard to evidence and the recommendations we could make from that. And each of those content areas included a brief statement of the problem, a synthesis of the available evidence, and recommendations for action. So this was a way that we were able to sort of bring the research literature, again, which often is heavy with elements of research, of studies that policymakers aren't necessarily interested in. This is a way that we could distill this down into points that were relevant, that would resonate with policymakers on this issue. After that report was issued, as I said, we went through a large process of disseminating these recommendations that involved the people involved, highlighting it on their websites, having meetings with people that we had standing relationships with, talking with the media about it, and holding briefings and meetings with policymakers. Once we got those meetings, a lot of educational forums were happening, and we're in round 2 again, and we're in the process in the 3 states represented here of setting up the kinds of educational forums and meetings with legislators and other stakeholders that will get the evidence into the hands of people who can do policy that will be responsive to the opioid epidemic in their states. As we move forward following that engagement, it's very important to be willing to provide technical assistance to the groups that we're working with. So conducting activities like helping with drafting policy, updating the available evidence, and being available to testify when bills come up or provide comments on different rulemaking processes. So again, I'm going to now turn the podium over to our 3 states, representatives from our 3 states, and ask them to update us on sort of phase 2 of this process and what's going on in each of the states. Carrie, would you like to start off? We can sort of start alphabetically and geographically from the west with Iowa and hear about your activities underway in Iowa.
All right. Thanks, Shannon. All right, good morning. My name is Carrie Castile, and I am an associate professor of occupational environmental health at the University of Iowa. I am also the associate director for the University of Iowa Injury Prevention Research Center. And I'm thrilled to have an opportunity to work with my colleagues here from the 3 sister centers on this project. Sorry, let me get myself a... There we go. So our team at the University of Iowa includes myself, our center director, our communications director, our outreach director, and a policy advisor. So what I want to do is just start with a little bit of background about the issue in Iowa. So the rates of prescription opioid overdose deaths in Iowa is smaller than it is in many other states. However, we do see trends in these deaths that are very similar to what you see nationally, both from the perspective of the prescription opioid overdose deaths as well as heroin deaths. And then when you look at the prescription opioid overdose deaths by county, the counties in the darker shades of red are counties with higher rates of overdose deaths. Those in lighter shades are lower death rates. And so there is some variation by county that we're seeing in the state. And what I've done here is that I've circled kind of where our urban centers are in the state. And you can see that those counties have higher rates of prescription opioid overdose deaths. So the state, the more southern counties are some of the more rural counties. And so you also see that there are, or we're also seeing that there are prescription opioid overdose issues in our more rural counties as well. So what we did as part of this project is we wanted to do an inventory of the policies and programs that were happening in our state to address the prescription opioid issues. We did go to the report that Shannon had mentioned. There are recommendations around these 8 different topics. Shannon showed you 7 of the topics, and I believe it was in the updated version that's coming out, surveillance was added. So I believe that's the eighth category here. So what we did is we put together an inventory and found that Iowa, we didn't really find that Iowa was doing all that much around this issue, but I did provide, I want to give you some examples of what we did find. So in terms of prescribing guidelines, the Iowa Board of Medicine takes, and we pulled this right out of the administrative code, takes a reasonable and responsible approach to prescribing. So there isn't anything in particular that's specific or standard about prescribing guidelines in the state. Physicians are encouraged to use pain management agreements, and these are specifically for patients who are prescribed more than 90 days of a prescription opioid and who have been deemed to be at risk for abuse. But these agreements are not required. It's something that's encouraged. There is, however, a mandatory continuing education licensing for physicians who do provide end-of-life care and chronic pain management. In terms of the prescription drug monitoring program, Iowa does have one. Physician registration and use, however, is not mandatory, and physician registration is actually quite low. It's far below 50%. Third-party payers, licensing boards, law enforcement only have access to the PDMP through legal compulsion. And researchers do not have access to the data. We can request aggregate data that we have to pay for from our PMP. So we do not have access as researchers to the data. So right now in Iowa, the PMP data are shared with states in the states surrounding Iowa as well as in Kansas, but there has been a bill introduced to expand information sharing across all states. In terms of addiction treatment, the state does get SAMHSA funding for medication-assisted treatment. And there has been a bill introduced that would require Iowa Medicaid coverage of these treatment services. In terms of community-based prevention strategies, one of the bigger initiatives is this Eastern Iowa Heroin Initiative. It is a law enforcement-based organization that goes around to different counties. They do town halls to describe the issue of not only heroin, but also of prescription opioids in the perspective of data that they're able to get from hospitals in the county, from data that they get from law enforcement, and they really are out there to inform the community. And for overdose prevention and harm reduction, the state does have a standing order that authorizes pharmacists to dispense naloxone to first responders and individuals in a position to assist. So those are just a few examples of what we've been able to find through our inventory of programs and policies. So for the stakeholder group that we assembled in Iowa, one of the things that we wanted them to help us do is to help fill in the gaps of our inventory list and help us to identify the policies and programs that we just were unable to find as a research team. We also wanted them to propose new or modify any or suggest any changes to existing policies and programs, things that they thought maybe could be working a little better, or things that they might, or programs and policies that might be working in other states that could be applicable to Iowa. We want them to identify policy and program priorities to address in our state, and then help us to identify the next actionable steps in addressing these priorities. So I will say that identifying the priorities and identifying next steps is a process that we're working on at the moment. But we did have a stakeholder meeting last month. It brought 33 people from around the state, not including those of us from the Injury Center. So it was a fantastic turnout. People are really, really interested in this topic. And so we had representation from our Board of Pharmacy, specifically from our prescription monitoring program. We had representation of community and harm reduction coalitions. Someone from our Governor's Office of Drug Control Policy was there. We had several representatives from healthcare, specifically emergency medicine, nursing, pharmacies, psychiatry, and also treatment services. The largest medical insurer for Iowa residents was there. We had a couple of representatives from I'm not allowed to say their name, but they were there. We had an investigative reporter who had shown up. So this meeting was held in Des Moines. I'm from the University of Iowa, which is about 2 hours away. And we had worked with our communications office in the College of Public Health, and our director of communications helped identify somebody from the Des Moines Register to come, and we just thought that he was going to be there for a little while and get to know what was going on, but he stayed for the whole 4.5 hours and is interested in doing some follow-up afterwards. Our executive director from the Iowa Poison Control Center was there. Law enforcement was there. We had legislators. We had 2 representatives in Democrats from counties in the eastern Iowa area. And we also had staffers from our senators' offices that were there. Someone from the National Safety Council came, and then we had quite a bit of representation from state and local health departments. So what I want to provide to you is just some of the priorities that were identified preliminarily for our state based on this meeting. One that rose to the top was to provide education in pain management and opioid prescribing and dispensing very early in the education of physicians, nurses, and pharmacists. And that includes educations on how providers and pharmacists respond to any red flags that they might see in the PMP. So right now, there's not really a great understanding based on what our stakeholders were saying, that if a patient is flagged, first of all, the idea of high risk is not really well defined, but if somebody is identified as being at high risk, what are they supposed to do? The other thing that rose to the top, which I was pleased by as a researcher, was improved surveillance. These folks really saw the value in being able to link data sources across multiple organizations and agencies. They really wanted to have access to healthcare data, law enforcement data, the poison control data, and the prescription monitoring data. And really be able to see kind of the trajectory of somebody going through the system, hoping that they would be able to stop somebody before they get to the law enforcement end. And then the other thing that was also very popular was reducing barriers to medication-assisted treatment and other treatment like behavioral therapy. Right now, the insurance doesn't cover this type of treatment. People want it, but even though our state does get the SAMHSA funding to help support this, people are being turned away for inpatient care because there aren't any beds available. And oftentimes people can't afford it because of the insurance not covering it. So I did indicate those as preliminary because we did have people in our group who were more vocal than others, and we also had people that we invited that were unable to come. So what we did is that we took the priorities that came up, and then we went through all of the notes that were taken during the day, and we assembled a list of recommendations that came out from our stakeholders, and we put those together in an online questionnaire that we administered to all the meeting attendees as well as those that were invited. And we have asked them to identify their top 5 priorities, not necessarily in any ranking, but to identify the top 5 priorities, and for those priorities, provide documentation of what they feel the next actionable program and/or policy step would be. And that survey closes on May 12th, so we should have some findings most definitely by the end of the month. And that is where we are right now with this project. Thank you.
Thank you, Mary. All right, so moving east, we hear from Michigan.
Good morning. I'm audible from the back, I assume. And everyone's sitting back there because they either didn't do the mandatory reading or are afraid I'm going to ask them a particularly difficult question. Okay. I'm Aaron Dorolaski. I am a research fellow at the Injury Center at the University of Michigan and an emergency physician working in Flint. And I'm working with Pat Carter, who will do the second half of our presentation. So we're going to talk about the Michigan experience, and some of these slides may be eerily similar to Carrie's presentation. I'm going to follow the same format, and the only difference really is that we're mitten-shaped as opposed to being somewhat rectangular. So this is our team, led by Dr. Rebecca Cunningham, who heads our injury center. That's Pat and I. And then we basically have this is our kind of core PDO policy network crew that's basically full of not just experienced researchers and clinicians, but people with expertise in health policy and legal issues. And we are really excited to be part of this grant because it dovetails so nicely with so many of our other kind of ongoing collaborative efforts with other departments in psychiatry, in surgery, locally and regionally with our collaborations with other institutions like our public health departments and even with law enforcement at the federal level. Michigan is kind of probably, I'm guessing, between Iowa and West Virginia in terms of the burden of overdose, probably closer to West Virginia than Iowa. We were 16th out of the 51 states in Washington, D.C. in 2015 in terms of total overall drug overdose mortality. And this is state-level data looking at kind of specific types of drug overdoses, focusing on the green and the red. And you can see red is all opioids and green is heroin. And you can compare those to kind of the baseline illicit drugs like cocaine, which have been fairly flat. And you can see this is kind of reflects national trends. Interestingly, I'm not sure what unspecified might include, but that's an intriguing category. This is, and again, similar to Carrie's slide with county level data. There's probably some overlap here. The darker purple colors or the higher rates of opioid-related poisonings, whereas the circles are the number of opioid prescriptions written per 100,000 Michigan residents. And there's probably some correlation between these two. But what's interesting is if you look, Michigan is basically, the lower peninsula is divided into two halves where most of the population centers are in the lower half. So all of the kind of northern things, the fingers of the mitten, are more rural counties. And you can see how extraordinarily high the average prescription rates are, even if there are not enough deaths in those counties to calculate an accurate rate. So our opioid sales as of about 6 years ago were up to 8.1 kilograms per 10,000 Michiganders. We're prescribing on almost 500,000 units of hydrocodone per year at this point. And our rate of non-medical use is about 1 out of 20 people per NISDA back in 2010, 2011. We've seen a jump in hospitalizations. And despite having a doctor shopping law, more than half of Michiganders who died of an opioid overdose between 2009 and 2012 had filled a prescription in the previous 30 days. So again, I'm going to using the same framework. I'm going to talk a little bit about what we're doing in Michigan at the university level and at the state level. In terms of prescribing guidelines, the Michigan, so basically the Advisory Committee on Pain and Symptom Management came out with recommendations for continuing medical education. And their recommendations are that physicians and mid-level providers get at least 5 hours of CME per 3 years. And that's just a recommendation. There's nothing mandated, and as far as I know, there's no legislation pending to mandate that, although that's one of the topics we're exploring with our stakeholders. We have, at the university level, a third-year medical student course that's now required, that's actually was piloted by our surgical colleagues. And we at the Injury Center are developing a MOOC, I think with Coursera, is that correct, on safe opioid prescribing, which I think is going to be rolled out this year or next year? Next year. So. Pat and I are both emergency physicians, so our state level college of physicians has come out with guidelines for emergency department and acute care recommendations in terms of opioid use. And a lot of these are intuitive, like using shorter courses of medications for acute injuries and avoiding long-acting opioids. There's legislation pending in the state to restrict chronic opioid prescribing to less than 100 morphine milligram equivalents per day, and for acute and chronic pain to limit those courses to 7 and 30 days respectively. We're also involved in the governor's ongoing commission on drug overdose and prescription opioids. Carrie talked about PDMPs. Michigan has one, I think. I think there's still one state that may not have one, or Missouri, maybe? Yeah, and like a lot of those, we went to APRIS. So now there's I think they have like 47 or 48 states use this software. So that may be helpful in terms of collaborating in the future, especially in research areas. There's pending legislation in the PDMP area where they're going to mandate in 2020 that physicians other than hospice providers use it, and there will be repercussions if you don't. That's pending. It's again, you can imagine, somewhat controversial. In terms of our kind of overdose education in naloxone, since 2013, we've had a law in place signed by Governor Snyder requiring EMS to be trained in the administration of naloxone and carry it. In fact, all first responders are supposed to be trained. And there is pending state legislation to basically allow pharmacists to write naloxone and basically have a standing order. In terms of addiction treatment, we have a pilot pending to basically a hub and spoke model to provide buprenorphine, at least referrals out of our emergency department. And of course, there's some programs like in Yale's program that it's actually prescribing, has piloted prescribing buprenorphine out of the ED itself. So this is kind of building on some of that. There is an addiction medicine fellowship at St. Joseph's, which is one of our U of M affiliates. And of course, Governor Snyder did expand Medicaid under the ACA. So MAT is covered, but like many states, we have relatively few prescribers of buprenorphine, and of course, there are limitations on how many patients each buprenorphine prescriber can have. So our programs tend to be oversubscribed. In terms of community-based prevention strategies, so surveillance, we're involved in a program to develop a pilot surveillance system for the state, and we're working on both our regional hospitals, our EMS providers, our medical examiners, and law enforcement, in this case, the high-intensity drug trafficking area, to develop a real-time surveillance system for opioid overdoses. We are involved in collaborations with our local public health and treatment providers as part of the Washington Health Initiative, and I mentioned our surgical colleagues innovated this program, Michigan Open, which basically revolves around post-operative prescribing, and they do other programs like take-back programs. So I'm going to turn it over to Pat, who's going to talk about our process for identifying and engaging stakeholders.
Thanks. Thank you guys for having us. As Aaron said, he kind of gave you a nice landscape of where things sit in Michigan. And as Carrie said, what we tried to do with engaging our stakeholders was to kind of fill in sort of what the holes were in our knowledge base, as well as to figure out sort of what the priorities and what the competing and controversial issues were within Michigan and our state. And so we started with sort of an open, unstructured process to kind of generate and brainstorm some ideas about who both local, state, and regional policymakers might be, or stakeholders might be. And then we both partnered with ongoing efforts at the state to hold a stakeholder meeting, as well as we've conducted our own series of semi-structured stakeholder interviews on a one-on-one basis with people that we thought would have important information to give us. And the process for that was we took the Johns Hopkins content areas and we restructured all of the recommendations into questions that we could ask of our stakeholders, and then with subsequent probes underneath those to get their opinions on sort of where their organizations or their or their action fit within the framework of those policy recommendations. So the first thing we did was partnered with our state health department, which has an ongoing effort around prescription drug overdose, and they had an already scheduled stakeholder meeting that we attended, and it had representation from the Michigan Department of Licensing and Regulatory Affairs, which controls our PDMP system, as well as the Department of Human Health Services, pharmacists, physician groups, as well as our Poison Control Center. And the discussions that day centered mostly around the PDMP system, as well as current prescribing practices and surveillance systems and needs for surveillance in Michigan. And then outside of that, we've had a number of stakeholder meetings with people both within our own organization, which is Michigan Medicine and the University of Michigan, including with folks from pharmacy and our substance diversion program, and folks within our addiction treatment program, as well as outside of the Michigan system itself at the state level, as well as through physician groups and epidemiologists within Michigan and other local hospital groups. And then we've had an ongoing collaboration with some of our state senators' offices around piloting expanded access to medication-assisted therapy, and so we've had ongoing meetings with them around this issue. So here's some of the examples of the questions that we developed based on the Johns Hopkins guidelines. These are ones specifically around prescribing guidelines, and we had probes underneath each of these to kind of get opinions around the different topic areas and the different policies. And again, some other examples of questions for acute pain management. Some of the themes that came out in our discussions with stakeholder groups are similar to what you heard Carrie present. There's clearly a consensus that this is a problem, and it's an iatrogenic one that physicians and physician groups have a strong hand in having created, and that policy solutions are necessary. The degree to which those policies should be mandatory and regulated is, I think, a point of contention and controversy, but there's a lot of agreement around that we currently lack the data that we need, both data for surveillance of deaths as well as more upstream factors around non-fatal overdoses. And there's a lot of interest in the PDMP program, and Michigan has just rolled out their new PDMP, and are similar to Iowa, we have a relatively low physician registration rate. I think it's about 38% of providers. So there's some goals with the new system to try and increase registration, but it is not currently mandatory, although there is legislation, as Aaron said, pending around making it mandatory. And there's a lot of interest around trying to integrate our PDMP programs into electronic health records, both at the local practitioner level as well as the large health system level. And there's a lot of interest around alternatives to opioids for both treating acute pain and prior to moving towards opiate in terms of long-term pain management, and better education of trainees and current providers and pharmacists. The main sort of controversy over what to do and how to do it really focused on whether or not these types of policies should be mandatory. And we heard a lot of pushback from kind of physician groups around limiting the scope of their practice or intervening in the scope of their practice. And so I think bringing those groups together is going to be an important point of moving this legislation forward and trying to intervene on this issue. And and then how to kind of fund these efforts at the state level and obviously at the federal level. And there's a lot of money coming from the federal government, and so hopefully it can be directed in appropriate ways to kind of address these issues. And I will move on, I guess, to Rob.
I'm from West Virginia.
Sorry.
Oh, no, you're good. Thank you. So the benefit of being last is that you've heard everything already. So I can pretty much say, yeah, we did it too, and we can sort of move forward. I am Rob Bossert. I'm the director of West Virginia University's Injury Control Research Center. In addition to myself working on this, we have our deputy director, Herb Lynn, who is really he was our associate director for outreach. He has now become our lead for opioid-related overdose initiatives within the state in coordination with our center and state and community representatives, as well as Sarah Warfield, who's a graduate student who's working with us studying opioid overdose prevention. Robin Pliny, who's the new associate professor with the university who's just joined us, who looks at harm reduction strategies, and several state partners. We have a problem in West Virginia. You may have heard. Opioids and rates of overdose in West Virginia are sort of high, around 41 per 100,000. This graph is West Virginia specific. It comes from our West Virginia Office of the Chief Medical Examiner. And it clearly demonstrates what's been happening in our state. Most importantly, we have a dramatic increase in heroin-related overdoses beginning in 2012, consequently directly related to implementation of our PDMP within the state. One thing I think that might make West Virginia unique from the other states that you've heard is we're a relatively small state, 1.85 million people within our state, 55 counties geographically, rather contained with small number of administrative units. But we're a fairly heterogeneous state, even though people think about us as nothing more than Appalachia. We have a fair degree of difference between our regions, and we're divided into 6 different administrative regions. I think what makes West Virginia University and the Injury Control Research Center at West Virginia University unique is that we have direct ties as a land-grant university in a relatively small relatively small state with almost every state and local office you can think of. So we're directly involved with most of the opioid overdose prevention activities within the state. The challenge for us in conducting this exercise is really not one of reach or engaging with stakeholders. It's one of coordination of activities and frankly, manpower. The amount of days and hours we have in a day and the number of days we have in a week. West Virginia, I'll keep the slide up here for a minute and just talk a little about what we've seen in West Virginia to lay the groundwork for the rest of the discussion. Is certainly aware that we're in the midst of well, people want to say epidemic, and I guess I'll use that term, but frankly, I think it's more of a crisis than an epidemic, and we can discuss academically what that means later on. But we're in the midst of an opioid overdose mortality and morbidity crisis, and certainly things have shifted on us. All you need to do is take a look at the literature, and everybody has their explanation for why. It's frequently attributed to coal mining, manual labor jobs within the state, low levels of education, and a high prescription rate. Many of you, I'm sure, have seen or heard about some of our towns with less than 400 people dispensing more than 4 million doses of prescription opioids within a relatively short period of time. That's certainly true. Where the state has done and tried to be responsive in clamping down on many of those practices. And as you'll see in a minute, we've got a number of different initiatives underway to try to reduce access to prescription opioids. Heroin, of course, is yet another problem, and the influx of heroin. Most recently, and I'm sure many of you saw this, we've seen an influx in fentanyl and carfentanyl within the state. We're hearing now from our Office of the Chief Medical Examiner and from law enforcement that in many cases those using carfentanyl or fentanyl-laced heroin products are not aware that they've been laced with fentanyl. In fact, in one case it was pure fentanyl, and they weren't aware that it was fentanyl. We had a cluster of overdoses within one of our southern regions, cities, Huntington, where there were 26 overdoses within 90 minutes as carfentanyl made its way into the state. So I give that background to say, ideologically, there are lots of interesting things going on. Data that I didn't put on a slide, but I'll share with you as well, is one of the things that might make West Virginia unique is our healthcare system provides care for a large proportion of the state. So West Virginia University Healthcare System includes 6 hospitals and 61 outpatient clinics, and those data are available to us centrally. So we have a bit of a surveillance point to take a look at what's been happening within our state. One of the things that we also know has been happening is the ratio of overdose mortality to inpatient admissions for overdose has been inverting. Between 2008 forward till about 2009 or 10, we saw more overdoses, more lethal overdoses than we saw admissions for non-fatal or morbidity, inpatient admissions for overdose. That is inverted. We are now seeing more inpatient admissions for overdose than we're seeing overdose mortality. That's a good sign, I suppose, except we also just recently looked at the 12-month repeat overdose risk within patients treated in WVU healthcare systems, and that has jumped dramatically. It's more than tripled in the past 5 years. Where we were seeing about 8 or 9% of our patients treated for an inpatient admission for an overdose each year had a repeat overdose within 12 months. That has now jumped to over 40% in 2016. So nearly half of our patients treated for an opioid-related overdose are seen again within the next 12 months for a subsequent overdose. So there are lots of things that we know. One other data point that I'll just throw out there for you to consider, the rate of admission for inpatient overdoses and whether it was illicit or prescription opioids has definitely changed, most dramatically among people 35 to 64 years of age, where the increase in illicit opioid overdose has jumped by about 80% a year since 2012. So we're seeing dramatic changes in the composition of what we're dealing with an opioid crisis, as well as the characteristics and the availability of the substances that they're using. We have a lot of initiatives going on and a lot of strong partnerships with the state. I put these up here to give you some context around how we try to manage this activity. As already been noted, there's certainly a lot of federal attention on this crisis, and certainly a lot of resources that are being directed towards states to manage and try to mitigate risk. Part of what we're doing is the Injury Control Research Center at West Virginia University is the state's focal point for distribution of naloxone to communities. Like other states, West Virginia passed legislation that made naloxone available through community pharmacists. So anybody who wants a prescription for naloxone can go pick one up from their local pharmacy, as long as they're willing to pay for it. The public insurance, or the largest insurer within the state, which is our state's insurance agency, currently does not cover that. However, it is available. So we are also trying to make it available. It was already mandated on all EMS units. In 2013, it was also mandated that law enforcement would receive training on administration of naloxone, and they would carry naloxone. We've recently begun distributing naloxone through a grant from the state. Last September, they were kind enough to make available nearly $1 million for us to go out and buy a bunch of naloxone, nasal aerators, and rescue kits, and we're in the process of distributing those throughout the state. As part of that process, our Deputy Director, Herb Lynn, went into each and every community across the state and identified every single community program that was attempting to distribute naloxone. Not official EMS or law enforcement agencies, but community-based groups, and identified over 80 community-based groups that were attempting to distribute naloxone or trying to find naloxone. And he prioritized them based on their level of need and the risk for overdose when those communities has begun distributing those. He's already distributed over 4,000 naloxone kits to community partners throughout the state. So we're actively involved in naloxone distribution, working with Project Lazarus and Fred Basin, who has been a key partner for us on that. We're also partners with the state. We work together with the state very closely, both in the pursuit of federal funding to address the opioid epidemic, as well as carrying out those exercises and evaluating them. So we're working, we were lucky enough to receive one of the prescription drug overdose prevention grants from SAMHSA last year, and we're working on carrying forward the SAMHSA activities. The CDC grant for enhanced surveillance activities. So like other states, there's a lot of interest in bringing together the data resources we have. Like other states, there are a lot of limitations for those as well. We have a PDMP. It's not mandatory. It is strongly encouraged. And like other states, we don't have access to that. Researchers don't have access to it, and even many clinicians don't have access to it. I didn't do as many slides as everybody else because I kind of counted on being last, so I'll just tell you some of these data points. There's new legislation working its way through the state of West Virginia state legislators that calls for registration of any opioid overdose and any purchase of naloxone from a community provider in the PDMP. We are opposing that legislation. We were called upon to provide commentary on the legislation, and we're opposing those additions to legislation. We're worried that registering purchase of naloxone in a community pharmacy will be a disincentive to step forward and obtain naloxone. So we're a little bit worried about the consequences of that sort of legislative action. However, that legislation would also make the PDMP data available to deans of medical schools so they could conduct some sort of awareness and surveillance of prescribing practices or PDMP use among their providers, as well as researchers. It would expand access by researchers. A related initiative to the PDMP initiative is and part of what's complicated our process in the middle of this exercise, we had elections and we have a new governor. And with the governor came a bunch of legislative change. So we have a new Secretary for Health, and we have new leads for our Bureau of Public Health and our Department of Health and Human Resources, and all the relationships that we had developed over the years now have to be redeveloped and reconstructed. Some good came out of it, though, and I'll mention some of those things that are on. But one of the new initiatives that was just recently introduced is not actually in place yet. It's development of a governor's office for drug control policy that will be responsible for coordinating activities around the opioid crisis within our state. MEDRS also came to our state recently, which is good because it gives us yet another set of integrated data that we can look at opioid overdose and activities, and we were already funded for prevention for states. In fact, that's where the money came from for naloxone distribution and acquisition. CDC allowed us to repurpose that money and purchase naloxone with it. We are actively involved with training for EMS and law enforcement around naloxone distribution through what we call our STEPS laboratory, our simulated treatment laboratory, where they can come in and receive treatment. The Office of Emergency Medical Services is responsible for doing that. We already have guidelines for prescribing opioids, and like University of Michigan, we have a curriculum for our third-year medical students in prescribing opioids. That's medical school-wide. That was developed in collaboration with the School of Pharmacy and the School of Medicine. So lots of ongoing activities. There's a governor's transition team. As our new governor came in, there were several of us, myself included, from West Virginia University, Marshall University, and others around the state who were called in to serve on a governor's transition team to provide recommendations for the opioid crisis within the state and how that crisis could be managed. One of the results of that, fortunately, was the creation of this governor's Office of Drug Control Policy. There were several other recommendations that are moving forward, including things like forgiveness for first-time felonies for controlled substance to allow people to return to the workforce. There's also a substance abuse task force that's university-wide within West Virginia University, where we work closely across the different schools within the university to coordinate efforts, keep awareness high, and to push forward many of these things. So we have identified at this point, we have not engaged our stakeholders formally yet in a meeting. The governor's transition leadership within our state has put us a little bit behind in that. We anticipate a meeting later this month and have identified several key offices, many of which are our partners for the Department of Health and Human Resources and the governor's office. We have routine communication with our state legislatures and with our senators' offices, trying to maintain a high degree of awareness of what we're managing within the state. We do know that we have problems, and we're working with the state to do improved mechanisms for data sharing. Like everyone else, we know that surveillance is going to be key for understanding what makes a difference. If I can get up on a soapbox for just 1 minute, what happens in these crises often is a lot of resources are thrown at states or organizations to try to manage these crises, and you end up with implementation of program after program after program, and nothing that helps you understand what's actually affecting change. I guess I'm an odd researcher. I'm not looking for the magic bullet or the precise measurement. I'm looking for something that actually can guide programs, that helps us understand what worked and what didn't work. I'm willing to sacrifice precision for impact. And in that regard, we're working to try to find data that can be used rapidly. The CDC grant's going to help us with that, but certainly we have a long way to go. So we're working with the state to try to improve that, and we have partners from all the collaborating agencies. For surveillance, it's the Office of the Chief Medical Examiner, Office of Emergency Medical Services, Bureau of Public Health, and the Health Authority. Perhaps one of the most important changes that came in with our new governor is he is mandating, along with the new Secretary of Health, that there's new legislation that will move all of these data systems that have impact on awareness of opioids from the different offices into a single Bureau for Public Health. So our inpatient data, our emergency department discharge data, our PDMP data, the EMS data are all being moved from the Office of EMS and the Health Authority into the Bureau of Public Health, so that they be a single point for access, and they're hoping improved utilization across the state. We just had a meeting last week with our state legislators and representatives about how to work together with the universities to establish analytic centers of excellence so that these data can be used rapidly to inform state policy. So I can tell you things are moving and there is engagement. Formal evaluation of programs. We're working on a rapid cycle of evaluation to continue modify or de-implement programs, and working with our state legislators so that we can have a rapid cycle of feedback so that when we have evidence that something's working, they can continue to support that. If it's not working, they can de-implement it, and if there needs to be change, they can change as well. A coordination of efforts to development and continued support for opportunities for continuous learning. We have, as I said, an extensive network of partners throughout the state, and we are holding monthly meetings with those partners to be able to develop a learning community so that we can gather information in areas that are working, areas of need, and make sure that everyone's aware and direct resources when appropriate and when available. Like others, we're trying to find better ways to use data. We hear about evidence-based strategies, and certainly knowledge translation means taking what works into the field and making sure it works there. That often starts with data about what works, whether it exists or doesn't exist. Where it doesn't exist, we're trying to gather the data. Where it does exist, we're trying to make sure that others are aware of it through things like learning communities and through regular transmission of information. Part of the CDC grant was this effort to do predictive analytics to try to predict who is going to be at increased risk for overdose mortality. That project has stalled a little bit as Office of EMS tries to figure out how to bring together those resources, but certainly it's an opportunity for partnership with the university and opportunity to perhaps move the field forward a little bit by having a continuum of use of data from understanding who's at risk to understanding what works. And we continue with the multi-domain assessment of communities. So one of the biggest challenges we have is identifying where the communities are and what the communities look like who are struggling with this crisis and where opportunities for intervention are. I will leave you with these two thoughts. Even though we're a relatively small state, our opioid crisis varies tremendously depending on where you're at. I did not include a map of counties, and I apologize for that, but our primary opioid crisis is in the southern part of our state. It is not in the northern part of our state. It is in those border areas around the state's capital and the lower rural communities. We also have the Eastern Panhandle and the north central part of the state. What's interesting, I suppose, from a resource allocation and etiologic standpoint is that the 5 counties with the greatest rate of opioid overdose account for nearly 40% of all mortality. So it's easy to identify where our hubs are and where the interventions are needed. The challenge for us, particularly as we move forward with this exercise, is coordination of those activities, because when you get into those communities, it's sort of like spaghetti. Everybody's everywhere. Finding a way to coordinate those activities and have information sharing in a way that doesn't step on everybody's toes and allows everybody to have the feeling of autonomy where they can move forward the way that they see best is the challenge that we're currently confronting. So we hope to have our meeting in May. We'll keep our fingers crossed to bring together all the state legislators, and this time is rather challenging, but certainly we'll move forward with making recommendations. We're currently reviewing all of the steps as well, trying to find out, check off those that have already been done in our state and those that need continued attention. And we'll provide an update at a future time. Thank you.
All right, well, thank you. Thank you to our panelists. I think that's a great way to kick off our morning. We now have some time allotted for question and answers. So as a reminder, we do have an online audience. So the AV folks at the back have reminded us that if you say anything in this room, please do say it into a microphone so that those who are joining us virtually can hear you and can be more a part of the conversation. Eric has a microphone over on this side of the room and is anxious to hear from you about your questions from our panelists. And if you'd like to come up to the front of the room, we can field questions among the 4 of you as they come in. Joyce, please start us off.
Good morning. I'm Joyce Dantzler. I'm with the Maryland Department of Health and Mental Hygiene. First of all, I would like to thank each of our panelists for some very informative presentations. My question is, I've heard each of you speak about state and local health departments being part of your stakeholders, and I know Dr. Bassart mentioned state health department as a data repository, but I'm wondering if you can speak more specifically about the role state and local health departments are playing in prevention efforts around this issue in your states.
Terrific, thank you. I think that sounds like a question for all, so whoever wants to start off, please do.
It passed left. I'll go.
You're all too polite.
Why not? So that's a great question, and I can tell you it starts with understanding where the ICRCs and the academic partners fit into all this. Ultimately, we recognize that this crisis is a crisis of communities and a crisis of the state. And coordination through the state and local, the community, county, local departments in the state is going to be the key to success. And so wherever possible, and I think it's in every case, we try to be a resource for the community efforts, try to understand what they're trying to address and the community needs before stepping forward. The resources available in the exact programs differ by community. We have harm reduction clinics in Morgantown. We have a harm reduction clinic down in Charleston. We have a harm reduction clinic over in Huntington. There are 4 or 5 others that are getting started. We try to provide consultation to them as they move forward and work with them to try to support any research activities. So in large part, our role becomes trying to find grants and support them in either implementation of programs or evaluation of those programs. At the state level, as you saw, we try to partner whenever possible on the development of proposals for funding or evaluation of proposals, or provide a resource for reviewing proposed legislation, or just be there to answer questions as they come up. But you know, I suppose the best answer is it sort of depends. The one thing I've noted that 40% of our mortality comes from the 5 counties with the highest mortality. There are 8 counties that have seen almost no opioid mortality for a couple of years now. So those communities are certainly aware of the sort of risk of opioid overdose and opioid abuse within those communities, but their needs are very, very different than the needs of these other counties where they're struggling more daily with this crisis. So you know, we're in every community, we're working with everybody we can, but it depends on their need. I'll pass right.
So, yeah, I mean, I'll echo that as well. But, you know, in our county at least, many of our engagements with the Department of Public Health have been as part of a kind of countywide initiative that includes other public health entities, that includes local treatment programs, that includes social services for people with drug and alcohol use disorders. So we've been kind of part of a ongoing dialogue, and by which we end up getting very specific feedback about what's going on at a county level. In terms of the state, we've recently begun as part of a larger stakeholder group to kind of start getting data, figure out where data sources are, who's managing them, and how to integrate those into ongoing surveillance programs.
And I would just add to what Aaron said at the state level. Also, we've done a fair amount working in terms of programmatic evaluation, being sort of the evaluative component of programs that the state has ongoing.
So we had engaged with our state health department because we wanted to identify those community strategies that we felt if we went to the state health department, I believe our state is broken into 6 or 7 different regions, and there is a liaison with the state and the region that the person, this liaison, has connections with each of the local health departments and the local boards of health. And so these public health consultants, these 6 or 7 public health consultants, we felt would know what is happening at the county level and what the priorities are, because each of the counties have to put together a community health priority list. So we met with, so it was me and the communications director, we met with the 7 regional health consultants and asked them questions about, you know, the priorities of prescription opioids, you know, heroin issues. And they said, oh, that's substance abuse. You have to go to substance abuse at the state. And we had planned for, you know, a 2-hour meeting, and we were wrapping up in like 20 minutes. So, you know, we kind of came away with this, you know, newsflash, you know, prescription opioids isn't a public health problem in our state. You know, they were really seeing this more from an addiction perspective and treatment services, and not from primary prevention. So it was a big eye-opener that even some of our public health regional consultants, they just said, you know, our counties just aren't working on that at that level. You know, they're working on obesity, and they're working on smoking cessation, and, you know, they're working on other substance abuse issues, but not prescription opioids or heroin, and don't necessarily see it as a big priority.
Thank you. Oh, Joyce, yeah, did you have a follow-up? Sure.
So then would you say most of your work has been with substance abuse at the state and local level, maybe behavioral health? Have you seen any involvement from injury centers at your state or local health departments?
So in our state health department, so it's primarily substance abuse. And we had, from our state health department, we had a couple of people from our substance abuse program there to speak really about the priorities around the addiction services or treatment services. And then what was the other question? The injury centers. So the injury centers, our state does not have core funding for injury and violence prevention work. And so we try to pool resources between our injury folks and our Injury Prevention Research Center. But our injury folks don't work on prescription opioid work. I mean, it really is a substance abuse program issue. So, our state has tried to apply for some of the CDC prescription opioid, surveillance work, but has never gotten funding for it. So, our injury folks in the health department see this as an issue, being part of the field, but have been unable to bring in funds to do work at the state level. So, we partner as much as we can between the health department and the injury center.
And I think from our standpoint in Michigan, I think I alluded to it in what I talked about, but our first stakeholder meeting was really one that was held by the state and based on their initiative through their core violence and injury prevention funding. So that project that they had ongoing, that we collaborated with them in terms of their stakeholder meeting.
So it's probably not shocking in West Virginia, it's everybody. And so we do work with our substance abuse team, our behavioral health team at the state level. We also have a violence and injury prevention program. It does not receive core funding from the CDC, but is funded by the state, and they are the point of contact for a couple of these collaborative efforts, including the Enhanced Surveillance Initiative, the Office of the Chief Medical Examiner. At the more local level, we work with law enforcement frequently, EMS agencies, and community groups. Our harm reduction clinic partners, and there are 3 of them across the state, are absolutely vital for community-based partnerships, as well as the faith-based community and the private medical providers, as well as the federal medical providers. So it's a multi-tiered organization within the state, and our relationships are equally multi-tiered.
Other questions? Yes, Andrea.
Thanks for a great presentation by everybody. It's so interesting. I was struck by a couple things. One was that in Michigan, more than 50% who had overdosed had filled a prescription in the 30 days prior to their death. And then I think everyone spoke about the need to get more naloxone distributed. So I'm wondering what your thoughts are about directly communicating and educating patients and about their pain medication or their pain alternatives, and if you have experiences with that.
Yeah, air clinician, you should start.
Oh, sure. Yeah, so you can look at it from 2 different perspectives. One is that as injury prevention researchers, we're very cognizant of the need to do this. But I'll tell you, and Pat and I kind of work on the acute care side in the emergency department. It's somewhat difficult to actually put that into practice because, especially in the time constraints are kind of similar for providers whether you're practicing in an office or in an inpatient setting or in the emergency department, which is you have a very finite amount of time in which to have these discussions, and oftentimes there is a kind of push to make things as quick and convenient for yourself as possible, because quite frankly, although I think many of us will have a discussion about, what are the absolute risks, part of the problem is we don't really know, especially for people who are naive to opioids, what is the inherent risk of giving someone with an ankle fracture a course of hydrocodone for pain after they leave the emergency department. And the number suggests that it could be anywhere from 4 to 7% of people never having received an opioid may be at risk for misuse in the future or addiction. And once you have that discussion, then usually there are questions, because especially as people hear about this crisis in the press, once you raise the specter, then they may be worried. And then you went from what you thought was going to be a 45-second conversation about the need to call the orthopedic office and how to keep your splint dry to, well, what's the chance that I'm going to become addicted to these drugs you're prescribing? Do I really need these? And then we almost never have conversations about, safe storage or disposal of unused drugs. I mean, in some cases, they may be part of a pre-populated discharge instruction, but the fact is, I would say most of us don't really have specific conversations around those. We might say, here's a disclaimer, there's a little bit of risk, here's your script, and then we walk out the door. So I'll let Pat.
Yeah, I mean, I think there's Aaron, everything Aaron said, I think is on point. I think that there's obviously an opportunity for that discussion to happen. And I think we could, as clinicians, certainly do a much better job of having a discussion about risk in some state, even if it ends up leading to a longer conversation. It's just I think we have to do a better job of training clinicians both how to have the conversation and what the responses are. And I think that's part of what has to go into the training that is incorporated both at the medical school level and then at the CME level for providers who are in practice.
Go ahead.
So something that had come out of our stakeholder meeting that I didn't mention as a priority, but it certainly was part of the discussion. It was using public service announcements, and I think I may have prompted that because it was part of the report as maybe a suggestion. So they felt like having public service announcements, about, ask your physician about, so that it's helping to empower patients, helping to empower communities, to take more of an active role in understanding the what they might be prescribed. They also felt like there could be opportunities for take-back programs to provide education about, the prescription opioids and also about naloxone. One of the things that had come up around the naloxone, and maybe the panel members can speak to it, and maybe Rob, you in particular, was issues of sustainability. So that, we have these things in place, but, what are the resources to keep them, going? So those were some of the things that had come up in our meeting.
Go ahead.
Sorry. I might just add to that, the take-back program question. A lot of our surgical colleagues are really working on how do we incorporate a take-back program within the return visit after their surgery, so that they come in, they have their return visit, and now they're progressing in terms of their healing. And so how do you incorporate take-back programs within that component, and what do you need to do that? So, sorry, go ahead.
Oh, no, please. So I love the question about sustainability, and it gets into naloxone distribution in general. We're giving away a lot of naloxone, and we're getting funding right now to continue to give away a lot of naloxone for at least the next 5 years. But there's no reason to believe that people are going to, anybody, federal government, state government, is going to continue to find $1 million a year in their budget to give away naloxone. And at this point, my fear is that we just simply don't have the surveillance to tell us either where to give it, and currently the debate within our state is, do we give it to the patients of injection drug users, injection drug users or their families? Do we make it more widely available through prescription? Do we make it, there is the vision that everybody in the community will have it, so that anybody who needs naloxone can get access to naloxone? That's probably not sustainable, right? Some of the data that we have on hand where we're looking at and that's why I think some of these data points are so critically important, where we're looking at the prevalence of repeat overdose within 12 months, where we're looking at the number of naloxone administrations and whether you want to call them rescues or saves or reversals. We know that naloxone is being used. We know that it's not being used nearly to the degree it's being given out. So how much waste are we going to end up with is a consideration when you talk about sustainability, and how can you most effectively direct that naloxone to the people who are in need. The point that I think follows on with increased number of repeat overdoses and increased administration of naloxone, we're still seeing our overdose mortality rate go up, right? So understanding the etiology of someone at greatest risk for overdose mortality, which from what I understand from the literature, and I don't have data to support this from West Virginia at least, is someone who's overdosed more than one time, who's a long-time user with increasing tolerance, perhaps some disruption in use, and then return to use. So in fact, we may see the number of, and our data are suggesting this is true, the number of overdoses that inpatient admissions for overdose or overdoses with reversal may continue to climb at the same time our overdose mortality rate is climbing. So the most effective distribution points is something that I don't think we understand well yet. I think we need to get much, much better at doing that if we hope to have a sustainable effort in the future. First, for the first point, but more importantly, if we intend to have that particular intervention strategy result in reduced mortality.
Thank you. I just wanted to remind our online audience that we are taking questions from you as well, so please do submit those. We're checking those regularly. In the meantime, we'll go to Adlin in this, on the right side of the room. Make Eric walk a little bit. Okay.
Thank you so much for a wonderful panel. My name is Adeline Alchin. I'm a public health analyst at the Educational Fund to Stop Gun Violence. And I had two questions. The first one was for Dr. Bosarte. Did I get that right?
I like that. That has flair.
Okay. And I was curious about an initiative you spoke about with the governor talking about forgiveness for felony convictions. And I was wondering if you had thought about the implications that might have on, for example, purchasing firearms, because if you're convicted of a felony, then you're unable to purchase or possess firearms. It's a lifetime prohibition. And I was just wondering if that was something you had considered when talking about doing forgiveness for those types of convictions.
So no, firearms didn't come up. Although I would like to comment in that what I found interesting about being on a particular task force and talking about management of the opioid crisis was that there were very few discussions about things like increased access to treatment, which we know was a problem, increased public awareness, which we know was high, right? Overcoming barriers to treatment utilization. Well, the focus of the conversation was really how do we help people who've been affected by this crisis within our communities, most importantly families, right? So we have a high rate of neonatal abstinence syndrome. We have a couple of NICUs within our state that are dedicated to NAS babies. They are always full, I'm told. We have a high rate of people who are convicted of drug possession or drug felonies who then lose their individual rights, things like access to a firearm or the right to vote. So firearms, access to firearms was not discussed, although there's the pragmatic answer and then there's the legal answer, right? So from a legal perspective, being a convicted felon will limit access to firearms, well, legal and lawful possession of firearms. The more pragmatic answer is I'm not really sure that's a barrier to firearm access within the state of West Virginia, or it may not be in many places. It doesn't mean that we shouldn't discount that risk, right? But if you look at the rates of firearm-related mortality within the state and opioid-related mortality in the state, opioids are far exceeding firearm-related mortality at this point. Not to say we couldn't be setting ourselves up for another crisis and other public health problems if we don't address this concern, but I just don't think it rose to the top. It's an important point, not something that was discussed. The focus on restoring the rights of convicted felons, particularly those with first-time drug convictions, one of the challenges we have within the state of West Virginia as well is that we are a disproportionately old state, so we have lost many of our younger residents to out-of-state opportunities, as many of the jobs that people relied on traditionally have been lost to either automation or just a decline in those areas of employment. Our younger people are leaving the state. And those that remain face many economic burdens that contribute to this opioid crisis as well. So, it's in trying to keep people in the state, provide opportunities for people within the state, and manage these other public health crises, I think will be important. We did not talk about firearms yet. I will invite you to raise that with the governor if you'd like to be the one to sacrifice yourself on that sword. That's great. But it's something that I think is worthy of discussion.
Sure. Thank you so much. And I just had a follow-up question on a different subject open to anyone. I was wondering if you had incorporated any type of materials or discussion about stigma into creating new policies and practices, and just wondered how you address that when developing policies and programs.
Yeah. So yeah, of course. I mean, despite the fact that opioid use is apparently very prevalent within the state of West Virginia, we know that there are barriers to accessing care. We know there are barriers to treat. Now, many of those barriers are organizational barriers. We have 2 harm reduction treatment, opioid addiction treatment facilities within the state. One at Chestnut Ridge, which is at West Virginia University main hospital there in Morgantown. They have the capacity to treat 300 to 350 people at a time. They closed the waiting list down at 800, which is currently closed to accepting any new patients, and have to find a way to prioritize people. We simply do not have enough treatment providers to care for the people that we know are there. So we know that the stigma is a complex thing. There's the stigma associated with reaching out for help. We certainly have an at-risk population that's reaching out for help and asking for help right now. We simply don't have the capacity to give treatment to everyone who wants it. There's also, though, the recognition that we could interrupt this from either a primary prevention standpoint if we had more open dialogue about the risk around opioids, either through clinician or public health forums. But that is something that we believe it has to be informed by community values. So we are also engaged in public education announcements or public service campaigns. I feel strongly that those have to be informed by community values and community perspectives. And so the sort of one-size-fits-all public messaging to try to address stigma really doesn't work. I usually include a slide after I show a slide about bad things in West Virginia, followed by good things in West Virginia. Right? So part of my concern about this and part of the public health concern about this is that we're sort of generating stigma as we continue to focus on this, right? So the more we talk about the opioid crisis, the more we talk about death from opioids, the more we talk about the prevalence of misuse, the less likely people are to feel like they're contributing to that problem by yet being another person with an opioid problem. So we're currently working within Harrison County, which is just south of Monongalia County, where Morgantown is, working with the community to develop a community-informed, community-inspired messaging campaign. What's really interesting is we've engaged with a woman who's a PhD expert in health communication who does risk communication, and is working with the community, taking their cues from the community. And what's really interesting about that is in our first meeting with the community, they told us the opioid crisis is not who we are, it's where we are. Who we are is an incredibly proud people who love West Virginia, or love to be from here, and think this is the only place they would ever want to live. So part of our strategy in that campaign is to take that central message of it's not who we are, it's where we are, build upon that strength of a sense of pride in where they live and a sense of pride in their culture and their history, and move forward with seeing awareness of risk for opioid use and entry into care as part of a long history of taking care of yourself and pride in where you're from, rather than a stigma. No, that was long-winded, but it was meant to say that it has to be informed by community perspective and community values. Sorry.
You know, that was quite eloquent. I don't think So, I mean, I'll just add that, stigma did come up in our stakeholder meeting as something that we would need to address, and it did come up around the public service announcements and really framing those in a way where people felt comfortable asking for help and understood, what kind of questions that they could ask. So, yes, stigma did come up, but we don't have nearly as much going on, I think, as where you guys are.
So I just need to say I'm going to have to leave now, because anytime anybody calls me eloquent, it means I should leave before I mess that up. Which I will inevitably do when saying something that makes no sense whatsoever. That's coming.
It's too early, Rob. You can't leave just yet.
I have to leave on a high note. Just drop the mic time.
There'll be many more opportunities. Erin.
Good morning, everyone. I'm Erin Rainey, and I'm here from the Health Resources and Services Administration, which is a sister agency to CDC. And I'm listening to the presentations, and I'm sort of reflecting on the policy process and the importance of this research to practice, and then practice driving research, and that cycle. Earlier this week, Congress passed a budget, not yet signed by the president, that gives the CDC Injury Center $112 million to implement an evidence-based opioid overdose prevention program, which is about $40 million more than they expected. So they are currently scrambling, I'm sure, to figure out how to spend that money before September 30th. But that said, this brings up the point that sometimes the urgency of a public health issue is going to drive action, maybe even before we have the answers in research. So I wanted to ask the panel around, how can we best be prepared to have established relationships between, say, state health departments who might get a call to action like that from a governor's office or from a state budget to spend money and to drive change on a particular issue when we don't necessarily have all the evidence? We know we need to turn to research, but how can we be connected and have an infrastructure and a relationship between research and practice before that question is called?
Fantastic question, and right up the alley of translation. So what do we do when you all start getting calls from your state health departments or your governor's office as to how to spend a bolus of money very quickly? Where's research? Where's practice? Where's policy? How are you going to do that?
So it's a good problem to have in one sense, right? But I think it's to be there with the best available science, to have good partnerships with your state health departments. And then I think it's to one of the things that Rob alluded to earlier, it's to be there with a component of evaluation for whatever you do try and to see if those things do work, and then to be able to scale those up to a larger sense if they are working, or to de-escalate them if they're not.
I would just like to offer, since you may have ties back to the federal agencies, that $40 million of excess funding we'd be happy to take. So just BOSSARTE when you make out the check, yeah. You know, I'd like to take a shot answering that on a couple of levels. And in one, I think the reality of doing public health work and certainly doing work around that may involve some sort of public health crises means that you're going to have to cast off any belief that you're going to be able to do everything that's evidence-based, right? Public health response simply prohibits consideration of waiting for the evidence to accumulate before you take action. That, however, does not mean you cannot build the evidence base as you intervene. And having that groundwork with your state and local partners where they need to understand and value the importance of evaluation and an openness to de-implementing, even if consensus among your stakeholders is this is exactly the right thing to do. So there has to be that early conversation around, certainly we need to be able to respond, and we need to be able to take the available resources and put them in the community. We also have to have a process in place where we're able to subsequently evaluate those things that we're doing, and an agreement that we're going to stop it if it just doesn't seem like it's working. And that, I think that's the more challenging conversation to have when you have community partners or even county or state level partners who are absolutely committed to a course of action because it's either their belief that this is going to make the difference or their own personal experience, and your data simply aren't supporting that as a course of action. That's the sort of dialogue that I think is really important to have early on. The relationship building, I think we probably all do, so constant outreach to our legislators and our state offices, and sometimes it's probably more of a trying to figure out how to manage all the requests than it is trying to build the relationships, keeping that dialogue open. But I really think it's critically important to say, you know, this is going to be a process, and we're going to do this in a way that's informed by the data and informed by what's in the best interest of the people that we're trying to serve. And the other part to that is, I think, as researchers, we have to acknowledge those same things, that we have to be open to the idea that we may not be able to do the perfect study. We may not be able to wait for our evidence to accumulate. We can't be as rigid as we'd like to be in saying we're only going to do X, Y, and Z because that's the research process. We have to be able to say, okay, maybe you're going to implement this in a way where I don't have the process indicators I'd like. I don't have a perfect outcome indicator. But I'm going to try to figure out a way to evaluate what we're doing so we all have a way forward and we can accumulate the evidence.
I don't have too much to add. So our injury center at the University of Iowa has great connections with our state injury and violence prevention program. I am not from Iowa. I've been there for about 4 years now, and I am really impressed by the relationship building that has occurred between our injury center and our state. And that, you know, it really has become important to pool resources between the injury center and our state injury and violence prevention group. So, you know, and the relationship that has been built is one where, you know, we understand what our roles are, and understanding that, you know, our injury center can provide, you know, the evidence base, we can provide evaluation resources, and really hope that, you know, as programs are being disseminated, actually before programs start going out into communities, you know, that there's a conversation beforehand to include an evaluation component, so that it isn't, you know, a program that, you know, kind of, well, it seems like it should work, you know, kind of a thing. And that, you know, we really, even though it might be informed by the evidence, you know, we really want to make sure that it works, you know, when it's scaled up and out into the community. And like I said, I feel like, you know, our injury center and our state have a really good relationship, and know that, and they know that, you know, we can help with developing, you know, an evaluation and conducting the evaluation.
May I add one quick thought? I'm sorry. I just have to acknowledge that it's a lot of work to do that. So our Deputy Director, Herb Lynn, when he was identifying those 80-plus community-based naloxone distribution programs, he drove to every single community across West Virginia, personally met those people so that he could understand what they were trying to do, what the opioid crisis looked like within their communities, and how we could help. I would say on average he spends 2 to 3 days a week in his car, or in one of West Virginia's cars, driving around the state, meeting with community partners, driving down to Charleston. It's a 3-hour drive. Driving down to Charleston for the day so we can meet with state legislators and public health officials to make sure those relationships are in place. I think the important point is that there has to be recognition as well, and it's a challenge sometimes, I think, from a research and academic perspective to make sure our funding agencies recognize that there's value in that. Because ultimately we're funded as research centers, which means we need to conduct research activities and education activities. Outreach is a component of what we do. It's certainly necessary for all the things that we'd like to do. But I think it's important to recognize that it's a balance between achieving those sorts of relationships, having sustainable relationships that allow for rapid action when it's necessary, but staying true to our mission and the reason that we actually get funded, which is also to do research and educate in addition to the outreach programs. And then the university occasionally expects us to teach or be on committees or provide clinical care and all those things that go along with it.
I'd like to just wrap up this session by first asking that the practitioners in the room think about that question, and I'll give you a moment, and then I'd like to hear from you as to how we can better sort of look forward and achieve that balance that we're all talking about between practice and programs and the importance of evaluation. So what are your thoughts on how researchers can be more effective and engage better with our practice partners? And while you're thinking of that, I'll just sort of take moderator's prerogative to say that one of the things that I wanted to highlight, at least with this presentation, is that what you're seeing here is essentially a roadmap for translating research to policymakers. This is a process that we've used now in 4 different injury and violence prevention areas. It started off as an initiative in the gun violence prevention area, and has seen tremendous success in terms of engaging conversations with legislators, with policymakers of all types around evidence-based policy solutions to address gun violence. So I think that this is, by and large, a tool that we have mostly thought about as an agenda-setting tool. So we identify an issue that's important, we assemble the team, put together the evidence, and translate it in a way that's going to resonate with policymakers, that's going to be actionable. However, in thinking about Aaron's comment, I think it's important to recognize, too, that this kind of a process can also be responsive. So the usefulness of this tool of having the evidence base summarized with recommendations, I hope will be very helpful as sort of the checks start getting written and decisions are being made in states throughout this country, that we do have a resource that will speak to what we know works at the moment, and how that can guide decisions around programming that we can anticipate are going to be made over the next few months. And now do folks from agencies or organizations have any comments or want to respond to Aaron's question about how we can best be effective with regard to that research practice collaboration in the coming months as these federal dollars start to come down? Nothing. You've stumped the group, Aaron.
Tough question.
All right, well, it's an ongoing question that I think we're going to be grappling with, and I'd encourage us to think about that. Thanks for the question as we move throughout our day. Right now, I want to thank our panelists one more time.